Good afternoon, Senator.
Good afternoon. How are you?
I'm good. How are you?
Good. A little nervous. We've had fires in and around us, and the wind's been really, really pretty crazy today. So.
Oh no.
Yeah. So far, so good.
Good. Fingers crossed.
Yeah. Yeah. Exactly. Exactly. So you can hear me, okay?
Yes, I can.
Perfect. I'll put myself back on mute.
Alrighty. Hi, Scott.
How are you doing?
Good. How are you?
Good. Can you hear me all right?
Yep.
All right, then I will go on mute.
Hi, Senator.
Hello, how are you?
I'm good. How are you?
Good, thank you.
Good.
Okay, I'm going back to lurking mode for a while.
Okay. Hi, Keenan.
Hi, there, I got my audio working. I'll go ahead and mute now. Thanks.
Good afternoon.
Hi.
Hello.
My computer decided it was doing a full reboot, so I have to go through and bring up all the agendas
Oh no.
for the meeting.
It's the worst.
Do you have everything you need though, Representative? Or? I'm sure I've got it all. Just okay. Yeah, we had that happening with ours too, and we're petrified it was going to happen right during the meeting this morning. So at least you missed that window. Well, okay. Am I seeing the 900 agenda? I think, Jerry, the easiest place to find it is if you look for that email I sent Monday with the executive committee stuff. There's the expanded agenda for I-900 linked in there. The problem is, let me forward it to you right now. My email is working. Again, that was what prompted me to, nope. Oh, okay, thank goodness. It just, everything came through. And I just resent it on the top. Okay, great. What prompted me to, with LegTech was my email wasn't loading at all. Great, got it. Thank you.
And whenever you're ready, just let me know when you'd like to start the streaming.
You should start promptly at 1:30. How's that?
Okay.
30.
Recording in progress.
Welcome. Well, welcome to the Joint Legislative Audit and Review Committee. This is our I-900 Subcommittee public hearing. I am Representative Jerry Paulette, and will chair today's meeting. We will go through a roll call of JLARC members. So
everyone knows who is present from the Joint Legislative Audit and Review Committee. And then please remember to mute unless you are responding to the attendance call, and raise hands to let me know if you have questions. We will be having the JLARC staff presenting briefing report on implementation of the State Auditor's I-900 recommendations to the Legislature. And so that's a recap of what has been done with the recommendations. And then we will be presenting two reports. The State Auditor will be presenting two performance audit reports: improving K-12 students' access to behavioral health prevention and early intervention supports, and the Medicaid program integrity at the Healthcare Authority. So that is our agenda. And would staff please run through asking who is present from the Joint Legislative Audit and Review Committee?
Good afternoon. This is a roll call for the July 21st, 2021 I-900 hearing. Representative Berg. Here. Representative Fye.
Here.
Representative Frame. Representative Gaynor.
Here.
Senator Hasagawa.
Here.
Representative Hoff. Senator Lovelet. Senator Mullet. Representative Orcutt.
Here.
Representative Paulette.
Here.
Senator Rivers. Senator Saldana. Senator Short.
Here.
Representative Stokesbury. Senator Wegener. And Senator Wilson. We have 7 in attendance.
Thank you, Marilyn. So we're conducting the meeting today using Zoom video conferencing technology, and the meeting is also, I'm sorry, I just received a notice that Windows is going to shut down in 10 minutes. That could be a problem, and the vice chair may be taking over Senator Wilson if that happens.
I guess that's going to be me then.
And I think that'll have to be Representative Orcutt, because I don't
Okay,
think Senator Wilson
Okay.
here.
Let's hope that doesn't happen. Excuse me, everyone. The staff from the State Auditor's Office will be presenting the performance audits. JLARC members can let me, or if I am locked out for a few minutes, let Representative Orcutt know that you have a question using the raise hand feature. After the Auditor's Office presentation, the agency staff will provide comments on the audit reports, and members will open up for questions from members. We're also inviting remote testimony today from the public via Zoom and accept written testimony, of course. Staff supplied information already for registering in advance for public testimony on the JLARC website. And if anyone wishes to provide written testimony, it should be sent to JLARC at leg.wa.gov and see the website for more information. Your written testimony will be shared with all JLARC members and will be available to the public and on the JLARC website. So with that, we will move to a briefing on the implementation by the legislature on state auditors I-900 recommendations. Ashley.
Good morning, or excuse me, good afternoon, Mr. Chair, members of the committee. My name is Ashley Elliott, staff to the committee, and I'm here today to present the annual update on the status of the legislature's implementation of recommendations issued by the State Auditor's Office. In 2005, Initiative 900, or I-900, authorized the State Auditor's Office to conduct performance audits. And when the state auditor makes a recommendation to the legislature, I-900 requires JLARC staff to report on the implementation status of these recommendations every July. We track recommendations in reports over the previous 4 years, and once recommendations are implemented, we no longer track them. Detailed information about the recommendations that were open last year can be found in our report that was issued on July 1st. The information on this slide can be found on page 2 of our report, which includes the status of current and unresolved state auditor recommendations made to the legislature over the past 4 years. So for our current review period, we looked at 8 recommendations, 2 of which were made in 2020 and 6 of which remained outstanding from the previous 3 years. So 2 recommendations were adopted as presented in the audit. 3 recommendations were partially implemented. 1 had bills introduced but not adopted, and 2 had either some legislative activity related to the topic, such as discussions at work sessions, or we could not find any new information, or there were no bills introduced. And here are the reports with new or outstanding recommendations to the legislature over the past 4 years. So as you can see, there's a wide variety of topics. And the state auditor issued an additional 15 recommendations to the legislature over the previous 4 years that have been resolved, and they were resolved as follows. 6 were adopted as presented in the audit. 7 recommendations were addressed with a different approach, and 2 were resolved in another manner. So in that instance, it could be like the program went away. And that concludes my prepared remarks, and I'm happy to answer any questions. I'm sure the state auditor could answer some more detailed questions if you had any.
Unmute here, and thank you very much, Ashley. Are there questions from committee members, including for the State Auditor's Office? Ashley, would you be willing to go back to the slide with the first slide with outstanding audit recommendations?
Sorry, just a moment. This one?
Yes. And do you have any information there in regard to the one that was introduced but not adopted, or related or no information? Wondering if committee members might jog their memory about discussions about those.
Yeah, I unfortunately don't off the top of my head. I'm sorry. I've been,
Okay.
But I'm happy to get you that information.
That might be useful to share with the full committee, so that, and I would ask if committee members might be a resource that might be able to add to the report, because one of us might have been the prime sponsor or co-sponsor of the bill introduced but not adopted, and might have information about why it didn't move. Okay. Any further comment or questions from anyone? Thank you. All right. We'll now go to the state auditor's performance audit on K-12 access to behavioral health and early intervention. Really looking forward to this report. And I want to note that after the presentation, And questions for the state auditor staff. We have the following agency representatives to respond to the audit and answer member questions. Martin Mueller, Assistant Superintendent for Student Engagement and Support at OSPI. Dr. David Crump, Director of Mental Health Services, Spokane Public Schools. Erin Wick, Senior Director, Behavioral Health and Integrated Student Supports for Capital Region ESD 113. Mick Miller, Assistant Superintendent of Student Learning and Student Supports, Northeast Washington Education Service District 101. Carrie Waterland, Assistant Director, Division of Behavioral Health and Recovery for the Healthcare Authority. And Jason McGill, Assistant Director, Medicaid Program Division for the Healthcare Authority. I want to thank you all for making yourselves available. And let's kick off with the auditor's report.
Thank you, Nancy. Good afternoon, Mr. Chair and members of the committee. My name is Carolyn Cato, and I'm a Senior Performance Auditor with the State Auditor's Office. With me today is my colleague, Nancy Patino, who also assisted on this audit. Today, we are going to present the results of the K-12 Student Behavioral Health Performance Audit. We have 3 key audit findings. First, students' access to behavioral health supports really largely depends on what schools are able to provide at the local level. Second, the state's approach to student behavioral health is fragmented and lacks sufficient resources. And the final area is that fundamental changes are needed to address issues with the current structure. But there are incremental changes that state and local agencies can make to help improve student access to services. To address these findings, we make recommendations to the legislature to provide greater state-level coordination and direction to address the fragmentation in the existing structure. For the Healthcare Authority, we make recommendations related to Medicaid to improve the existing state's system's ability to connect students with behavioral health services. We also make one recommendation to the Office of Superintendent of Public Instruction to address the shortcomings in its model plan for recognizing and responding to students in emotional distress. In this audit, we evaluated the current prevention and early intervention efforts in behavioral health for students and asked these 2 questions. Are there opportunities for state agencies, educational service districts, and school districts to better identify and connect Washington students to needed services? And can state agencies, educational service districts, and school districts reduce barriers to accessing these services and improve coordination of them? Before we answer these questions, I want to provide a little bit of background. Behavioral health encompasses both mental health and substance use disorders. Providing prevention and early intervention supports can help prevent or reduce the severity of behavioral health disorders. If behavioral health concerns go undetected and untreated for students, they can lead to poor academic performance, dropping out of school, school violence, as well as self-harm or suicide. In Washington, 17.5% of school-age children have a mental health disorder, compared to 15% nationally. In addition, 5% of school-age children in Washington have a substance use disorder, compared to 4% nationally. Schools are a natural setting to promote student well-being, identify behavioral health concerns, and offer necessary interventions, given the large portion of time students spend in school. However, through the school survey results of almost 400 schools who responded, we found that only 42% of schools provide in-school supports that cover the full continuum of prevention and early intervention activities, as seen in the tiers in the diagram. Offering the full continuum of supports from Tier 1 through Tier 3 ensures that all students can access services that address their needs and receive exposure to universal supports. We also learned through the survey that few schools screen students systematically. We found that only 18% screened all students, and another 14% screened a subset of students to identify their behavioral health needs. This means that only about 1/3 said they systematically screened students. We found that the vast majority of schools said they train at least some of their staff. In addition, almost 7 out of 10 schools said they had a dedicated staff person or team to respond to concerns with students. We also found that over half of schools monitor data for all of their students to help inform their decisions regarding their behavioral health needs. On the next several slides, we will discuss why the state's approach to K-12 student behavioral health is fragmented. Currently, roles and responsibilities are assigned across several local and state agencies. This has resulted in no oversight of the behavioral health plans school districts are required to develop to recognize and respond to students in emotional distress. Also, there is limited ability for educational service districts, the Healthcare Authority, and the Office of Superintendent of Public Instruction to assist school districts with implementing the full continuum of services and supports to respond to students' behavioral health needs. Ultimately, we identified that there is a lack of strategic and comprehensive direction with no state-level oversight or guidance for school districts. Washington's decentralized approach has relied on school districts to develop the required plans to recognize and respond to students in emotional distress without oversight. These required plans include components such as identifying training opportunities and detailing how staff should respond to concerns. This audit found that only 3 of 20 school plans reviewed fully met state requirements listed in the blue box. We also found that OSPI's model plan, intended to provide guidance to school districts with developing their plans, did not fully meet state requirements. Until recently, there was no oversight of these plans. In 2019, the legislature assigned OSPI the responsibility to monitor them. They will begin this review process during the 2021-22 school year. Educational service districts are required to provide behavioral health supports to school districts through their regional school safety centers. State law required educational service districts to establish regional school safety centers as part of a statewide network in 2019. Responsibilities include many aspects of behavioral health coordination, such as helping districts with their required plans and facilitating partnerships with providers. However, ESD officials said because the legislative bill was not fully funded, they have not fully met these requirements. In July of 2020, the legislature funded 9 staff positions, 1 at each of the 9 ESDs, to provide further support to school districts in their regions. Now, my colleague Nancy Patino will walk us through the gaps in the current structure.
Hello, my name is Nancy Patino, and I'm a performance auditor at SAO. And continuing where Carolyn dropped off, there are gaps in the current structure that require improved state-level coordination. Well, we have our state laws directing local and state agencies to implement a patchwork of behavioral health requirements. There's actually no state agency designated to oversee behavioral health services in K-12 education. Both HCA and OSPI are not able to provide state-level programs or resources sufficient for school districts to implement comprehensive behavioral health systems. The legislature established the Children and Youth Behavioral Health Work Group, tasked with identifying barriers to access to behavioral health services for children. However, the work group's authority is limited to making recommendations to the legislature, and these gaps result in a lack of strategic direction with no state-level oversight or guidance for school districts. The state's current approach to behavioral health in schools lacks the needed resources to adequately identify and refer students to needed services. Funding and its restrictions hinder the state's main prevention program, the Community Prevention and Wellness Initiative that places intervention specialists in schools and is overseen by HCA. With a budget of nearly $32 million during the 2019-21 biennium, it can only serve 6% of public schools. And funding sources specify that funds must focus on substance use prevention, leaving a gap in mental health. The state's limited and piecemeal funding is likely inadequate to meet student needs. This means that school districts and ESDs must work within their own means or seek other funding to meet student needs. Leading practices recommend greater state level direction and coordination to help support school districts. This includes supporting schools to help them establish a behavioral health system, coordinating to promote goal setting across education and health agencies, establish an advisory council with representation from education and health fields in order to develop strategic direction, including building out a comprehensive behavioral health system in schools, providing guidance and funding to school districts to implement such a system, and establishing and monitoring student behavioral health activities using performance measures to track outcomes. Washington can do more to alleviate the current fragmentation around student behavioral health by designating one agency to lead the state's efforts. The lead agency would be responsible for coordinating strategic direction and local activities with key partners, providing technical support to school districts, and facilitating advisory council meetings. The legislature could designate a state lead agency from its two strongest candidates, HCA because it's the state's behavioral health authority, or OSPI because it's the state lead agency in K-12 education. Now that we have gone over the fundamental changes that are needed to address issues with the current structure, we're going to discuss incremental changes that can help improve the existing system. HCA can help educational agencies better access Medicaid services. Medicaid allows educational agencies, such as districts and ESDs, to become Medicaid providers and deliver behavioral health services in schools. Currently, only ESD 113 and Spokane Public Schools are Medicaid behavioral health providers, and 4 ESDs are in the process of doing so. They shared a variety of challenges they face going through this process, such as the lack of expertise to navigate the medical field, such as understanding what services are billable and reimbursable in school settings, the time and cost involved in billing multiple managed care organizations. This includes contracting with each managed care in their region and learning to bill each separately. They also lack the resources to complete the process, as they must make the initial investment to become Medicaid providers and cannot seek reimbursement until they deliver services. And HCA doesn't currently have specific guidance for educational agencies to use.
Nancy, Senator Short has her hand up. She has a question, it looks like.
Yes.
Thank you very much. Mr. Chair, do you want to be the person to acknowledge, or how do you want to handle that?
I'd rather they get through the presentation and then we ask our
Sure.
questions. Is that okay?
That's okay.
Oh, okay.
Okay,
Thanks.
that's fine.
So other states help educational agencies provide behavioral health Medicaid services. We identified 2 states to compare Washington to and met with their state officials. We selected Michigan because they established very comprehensive behavioral health services in school settings. They received federal approval to streamline the billing process for not only behavioral health, but also administrative services. They developed a program guide for school-based services, describing the provider enrollment process, covered services, and the reimbursement process. They also created an advisory council to support program implementation and establish performance metrics. These efforts were supported with $17 million from the legislature. We selected South Carolina because, like Washington, they have school districts contract directly with managed care organizations. They facilitated collaboration with the state Medicaid agency, the Department of Education, managed care organizations, school districts before transitioning their services under managed care. They also standardized a boilerplate contract between school districts and managed care organizations to use, as well as standardizing service forms for billing purposes. And they prepared school districts to bill managed care organizations over the course of 6 months, holding joint meetings and providing training and technical support to school districts. HCA could seek a federal waiver to expand student eligibility for Medicaid. More than 40% of surveyed schools identified parental reluctance to access services for their students as a barrier. When parents are reluctant, youth may be unable to access services without their parents finding out due to billing co-payments. HCA's current federal waiver can serve as a model to address this issue. The Family Planning Only program provides coverage to all students age 13 years and older to access confidential reproductive health services. It covers all youth, even those covered by private insurance or those that may be uninsured. HCA could seek the same waiver to expand student eligibility for Medicaid to cover confidential behavioral health services for students age 13 years and older. HCA lacks full assurance that Medicaid enrolled children are receiving behavioral health screenings. Medicaid enrolled children are eligible for periodic checkups, including behavioral health screenings, which are intended to identify behavioral health concerns early on. The audit examined 2018 and 19 data around well-child checkups. Of the over 400,000 children who received the checkups, our analysis found that only 45% had the screenings or were already receiving treatment or medication for behavioral health. One reason could be that providers can only bill for a screening conducted using a standardized screening tool. So if the screening is conducted through an interview, it's only recorded in the patient's record. This means that HCA would need to review individual records to ensure the screening occurred. HCA contracts with a company to monitor whether managed care organizations provide well-child checkups, but the contractor does not currently review medical records for screenings to determine if they were performed as part of the checkup. To recap, we made recommendations to the Legislature, the Healthcare Authority, the Office of Superintendent of Public Instruction. And this concludes the presentation of our audit results, and we would be happy to answer any questions that you may have at this point.
Thank you very much. Senator Short, would you like to? Yes, you've got your hand raised again, please.
Thank you, Mr. Chair. I appreciate that. And I think great presentation, both of you. One of the things, and you may have answered it, and it sounds as though this state would determine how it wanted to address the shortcoming. And I see you've used South Carolina as an example, but when I think about schools providing services, I mean, I'm assuming those services are provided by, you know, a recognized healthcare professional, you know, mental health professional, that it wouldn't be like, you know, like a school counselor. And I don't say that in a disparaging way. Our counselors do an amazing job. I just kind of wanted to understand that that's actually a separate position, and one that would go through more than likely like a healthcare entity.
That you are correct on that. I mean, there, as far as you have the school counselors who obviously address the academic aspect,
sure.
But then you also have the mental health component. So there may be, you know, districts that have personnel that are actually qualified within their districts to be able to provide services at different levels, and even at the ESDs as well. But you are correct about that, with making that distinction between the counselors as far as those addressing the academic side, as well as those that would be addressing the behavioral health side.
And I just wanted to quickly add that it also depends on the level of care we're referring to. There are some screenings that are evidence-based and they're used in schools where teachers or other school staff administer them. And if the screening shows that a student might have issues with depression or something, they can refer them to a mental health or substance use specialist. That's when we go to more of the licensed healthcare professional field. So there are some activities that can be.
Okay.
Yeah.
Sorry, I didn't mean to interrupt.
No worries. I was all done.
Mr. Chair, might I follow up?
Please do, yes.
Thank you. I appreciate it. One of the things, and both for the presenters and just for the committee, Spokane, the ESD in Spokane undertook a pilot project where they embedded actually mental health professionals in schools. They did it both at the high school level and the grade school level. Senator Patton and I actually received an update or kind of, how it went. And they found that over time, it did incredibly well. Students got to, to trust these individuals, and it just, they could help families, in the coordination of services and help, because we know what's going on at school is more than likely going on at home, the challenges that they have. And I just invite, and maybe Spokane might talk about that if they have information, but I think that would go a long way too toward maybe alleviating some of the parents' concerns, that 40% number. So I just wanted to bring that to the committee's attention. Thank you, Mr. Chair.
So I think what would be helpful right now, with the forbearance of Representatives Thai and Berg, who have asked, have questions in the queue, if we could hear from some of our guests, perhaps starting with Dr. Crump and other whoever else feels like they'd like to join in. But it seems like it would be appropriate for us to hear from our other guests about this. And just want to point out that Senator Short, your question was right, very similar to one I had, because when we were funding expanded behavioral health supports this year in the higher ed system, we explicitly said we want to ensure that they are people with graduate degrees qualified in terms of the funding stream, not asking the counselor equivalent of guidance counselors to do that work. Dr. Crump and anyone else would like to join in, just want to raise your hand. And I see Mick Miller.
Thank you, Representative Paulette, and thank you, Senator Short, for remembering this. I'm not sure if Dr. Crump is on the call, but we were the recipient of a grant, a federal Department of Education grant, in which we were able to embed 8 mental health therapists in 15 schools over 5 years, and we saw just incredible success. And as Representative or Senator Short at the time, Representative Short, and now Senator Short, mentioned, one of the big barriers that we did overcome was the fact that with the staff who were licensed therapists who were in the schools, developed a great trust with the staff as well as with parents. Now, while we have had 5 years of experience with this and success, and we have just become a licensed behavioral health provider in our agency and have begun some telehealth work. Capital Region ESD 113, along with Spokane Public Schools, as was mentioned in the report, have been licensed agencies who have Medicaid supported therapists in schools, and they have been doing this for years. They're truly the leaders within our state. And so they can probably speak to this to a greater degree than I can. However, I can say within our 15 schools and our 8 therapists that we had over, again, the course of 5 years, eliminating the barrier of transportation, developing relationships within the school to help get good referrals to our therapists, to help with universal screening, and to provide direct support, it was incredibly successful.
Thank you. Would anyone from ESD 113 or OSPI like to offer comments? And then let's see if HCA would like to offer some comments.
Thank you, Mr. Chair, members of the committee. Erin Wick with Capital Region ESD 113 and representing the Association of Educational Service Districts today. We have been a licensed behavioral health provider, as Mueller mentioned, for about 20 years. We have a couple of different pilot projects that we have been implementing, one specifically in Rochester School District, where we have both substance abuse and comprehensive mental health services. We believe our model does a fabulous job of building a collaborative approach to solving these issues uniquely at each district. Every district is different, just like every student is different. We create a multi-tiered system of support, so building that prevention, the bedrock of behavioral health within school districts, so that the school district staff and counselors and everyone within that system understands what it is that we're working on, providing the stigma reduction, the universal prevention, and then building on that with the early intervention. We know nationally that only about 5% of the students who indicate needing behavioral health actually access healthcare. So the timeliness of this is gives us a lot of opportunities to get this right. It's great that we're looking at states like Michigan and South Carolina. I do believe that some of the things that we are doing here in Washington State, such as our program here at Capital Region, some of the other ESDs that are doing programs, Spokane Public Schools, we really, I think, are doing it in a very small venue due to some of the funding constraints. But again, I think there is a lot of ways that we can look at scaling these projects to really bring them to life in a fuller model across our regions.
Thank you. I'm wondering, does OSPI or our guests from the Healthcare Authority either want to offer some comments?
Yeah, thank you, Chair Paul. My name is Martin Mueller. I'm the Assistant Superintendent for Student Engagement and Support at OSPI, and appreciate the opportunity to weigh in after making Aaron's comments. Speaking specifically to our the recommendation the SAO made to OSPI, we're in the process of updating that model plan for recognition, screening, and response, and we'll have that deployed out to school districts this next school year. And appreciate the collaboration with the State Auditor's Office to identify that and ways to improve it. I think we have a small set of districts that have the size where they can become licensed behavioral health providers in our state. And then we have some ESDs, as you've heard, that are moving forward with that, where they can bring to bear that support regionally to kids and families in the districts that they serve. But we really don't have a school-based behavioral health system, right? School districts aren't resourced to do that, and it hasn't really been the focus of their work. It's certainly, behavioral health concerns certainly typify some of the most common barriers that we see to academic success, and so schools are very interested in how to do that. But I would say, about 2/3 of our school districts have 2,000 or fewer kids, right? So what we really need to do is be building out our community-based behavioral health system, right? So kids, they function in families and they function in communities in addition to functioning in schools. And so to the extent that we can build out that community-based behavioral health system, where districts that have the right scale can do that, where ESDs can be a part of that community system, that's going to improve access across our state. And I know there's a lot of work going into that. Our adolescent behavioral health system struggles with workforce, struggles with reimbursement rates and those kinds of things. And to the extent that we're able to address those kinds of barriers on the behavioral healthcare side, then we're working with schools on the school side around strategies for co-location, how to do this smartly, what are the screening protocols in their multi-tiered system of support to quickly identify students and get them connected with an appropriate licensed behavioral health provider. That's the work that we see as most important for schools. We're very supportive of the idea of ESDs moving in this direction to the extent that it makes sense for them to do that, and they can kind of make it work, because it creates that, as Mick noted, a fairly, it removes a lot of those kind of structural barriers around access to a provider for a student in school. If there's a co-located strategy, and ESDs have this natural relationship with their school districts already across a broad range of initiatives as well. And doing this kind of behavioral health support work adds into that. So, so moving forward, we're really working on that system stuff on the school side around how do you connect better, and then we want to stay engaged as the auditor noted with the Children and Youth Behavioral Health Work Group to think of those system strategies on the behavioral health side where we can improve our system. I'll also note that a lot of the recommendations in the audit primarily focus on our publicly funded system, and in schools that's a subset of our students. You know, statewide it's maybe 50% of the students. There are districts where it's much less than that. You know, so again, I say that just because that highlights how important it is for us to be thinking about this from our broader community behavioral health system.
If I may just ask you to clarify that when you say 50% public funded, I mean.
Yeah. So Jason or somebody else from the Medicaid program at HCA might have a more accurate answer, but under Apple Health, you know, about half of our kids in schools are covered under Apple Health, the Medicaid insurance system. The remaining are either not insured or covered through commercial providers, and the audit didn't really address that side of the system at all.
And so that'd be a good segue to ask HCA to jump in, and including if you would address, don't we have a severe shortage of community-based providers who are able to take Medicaid and Apple Health youth at this time?
Yeah, that's right. Chair Paulette, thank you, and congratulations on your election to chair for JLARC. Thank you for having us this afternoon. My name is Jason McGill. I'm Assistant Director for Medicaid Programs at the Healthcare Authority, along with my colleague.
Hi, Carrie Waterland, Assistant Director of the Division of Behavioral Health and Recovery at the Healthcare Authority. And we just really appreciate the opportunity to talk with all of you today. Jason and I will be working in concert together and doing a little bit of back and forth. So we thought it probably easier to just be on one screen and talk to you at the same time. Fully vaccinated, wanted to point that out. And so we know we are socially distanced in a way, but also quite safe. So just really happy to be here. And kind of wanted to point out, we agree at the Healthcare Authority that there's really perhaps not a more important issue than the community behavioral health system, and really ensuring that the healthcare in Washington is providing behavioral health services that work. However, I do want to point out that this audit began as an audit of limited block grant funded prevention and intervention services, and moved to an expanded but limited review of behavioral health treatment services. Those are two different things. Even the final key recommendations before us say that our key recommendations are to improve the existing state system's ability to connect students with behavioral health prevention and early intervention services, when that's really not the case. The final audit recommendations focused predominantly on Medicaid-funded screening and treatment services, and made little mention of the non-Medicaid prevention and intervention services. We feel it's led to conclusions that are inaccurate and don't really fully portray the continuum of behavioral health services that we have available today, or the number of collaborative efforts underway to address the gaps that we have in the community system and the work that we're doing with OSPI. A key effort is really the legislatively driven Children and Youth Behavioral Health Work Group. This work group convenes many of the suggested partners that the State Auditor's Office recommends, and pulls together representatives from OSPI, Healthcare Authority, providers, legislators, and advocates, and they identify and support system changes as well as enhancements. There's actually a subgroup of that work group that is that was formed to specifically address school-based behavioral health services. And we believe that this structure, instead of creating an additional structure, is the appropriate mechanism for this continued collaboration and moving forward some of the recommendations from the State Auditor's Office.
And I might just add to your point, Representative Paulette, about workforce. And to Martin, I think Martin is correct in terms of about 50% now more our children in our state are covered by Medicaid. And so I think that's generally what we're talking about in terms of half of our children are covered. We also cover non-Medicaid youth who need coverage. And so Apple Health does cover all kids. Of course, we cannot ignore the critical portion of the population too that are insurance covered, commercial covered, privately covered individuals, and this audit did not account for that population. In addition, I think the one challenge not referenced in this report is the criticality of supporting our community behavioral health system. And Representative Paulette, I think you made the point earlier, we have enormous workforce challenges right now, unheard of in generations. And that is not an overstatement. I just spoke with a behavioral health agency executive who has been in this business for 40 years and has never seen the workforce challenges like we're seeing right now. So without solving that, we will not solve anything. And so that, I think, is our first and foremost priority. As an aside, integrating primary care and behavioral health is just as critical, which we have made some significant progress here in Washington. Physical health is a problem for many and can be the leading issue in terms of the condition. It might not be a behavioral health issue. So we can't ignore primary care. And of course, this audit, understandably, did not focus on that, but it is important to understand that it is a limited perspective. I would also mention that some of the salient points of the audit that I'd like to just touch on briefly, involving some other significant investments that gone a long way, including our school counselors. Legislature has made some significant investments in that. In addition to our school-based health clinics, I'm just looking at, we've got maybe upwards of 50 now in the state. I appreciate the ESD's reference to working as managed care. We've got some of those pilots underway. Our Medicaid administrative claiming program helps 49 school districts with $3.6 million of state funding. The school-based health care services program for people with individualized education program needs serves about 18,000 people with 11.5 million in state funding. So some significant work that the legislature has invested, in addition to, as I mentioned, counselors and school counselor supports. Okay.
And I think just lastly, the report makes some really relevant points that we're definitely committed to following up on, and we'll continue to work with school-based health centers. Much work has already been done to improve that accreditation and billing process and system. We're looking at improving the outreach and eligibility services to ensure that all children are covered. We look forward to expanding that effort to look at new ways to help support our school health systems.
And, you know, agency now, we're currently in a process of considering potential decision packages for the legislature and OFM and the governor's office to consider. And one we are thinking about is really expanding, you know, in Medicaid, you need a state match. Generally, you need 50% of the dollars are state funds to then match, the feds will then match the other 50%. And right now for our school-based healthcare services, that state funding was cut over the recession and really has not been restored. And so if we can have one pot of dollars for the state match, we think that would help schools enormously in terms of helping support that critical program, which then may free up resources to help them support, as Martin noted, whether it be a school-based health clinic, which is probably the best model, but may not be suitable for all schools. Maybe the size of the school isn't sufficient. So what are other tiered models, such as a managed care approach that the ESDs are, I think, brilliantly piloting now? And again, investments in school counselors and referrals, again, can't ignore the importance of ensuring we've got a community health system that works. I think we also have work to do in terms of other options in Medicaid, and we will redouble our efforts and commit to our ongoing interagency work group that has been led by OSPI, and we are very interested in continuing supporting that work to improve the system. We have made some improvements, so managed care works better for those schools who are interested in working with managed care. So again, really support the efforts from Spokane and some of our ESDs in that regard. And again, one other area that we're looking at to support our community behavioral health clinics is looking at a new federal model that has been out sort of piloted now for a couple of years, called a Certified Clinical Behavioral Health Center, or CCBHC. And that is something that we think might be a sea change for sustainability for our community behavioral health clinics. So we're looking at options along the lines of studying an effort to make that work here in Washington. So those are some of the ideas that we have, and happy to, stand for questions.
Happy to answer any questions. Thank you.
Well, Representative Fye, you've waited patiently.
Thank you, Mr. Chair, and I won't accuse you of stealing the thunder with your question, but you kind of did, but that's okay because you're chair.
But Senator Short had already gotten us there, so blame the senator.
Yeah, well, yeah, and I don't have the expertise that Representative Berg has given her work with school districts, but I was glad. I just would say it's more of a comment now, because I was going to ask about the availability of the right professionals to do this work, but it strikes me as this is a much bigger problem than the audit was taking a look at, and there really is a need. And I hope that people from I think the HCA people and others have talked about this. Maybe they want to comment, but this is a paralyzing situation with what's gone on with young people, especially in the last couple of years. And I just hope we can get a comprehensive set of initiatives out there to address the issue, because I'm glad to hear that one size doesn't fit all, but we need to cover the state in a way that is deserving to our young people. So I guess my question is back now to the HCA to feel like they have the ability and resources with others to put together a kind of a comprehensive strategy that the legislature can consider moving forward to help out with our mental health for our kids.
You want to take it?
Yeah, absolutely. This is Carrie Waterland with HCA. Thank you so much for that question. I think we have a really good opportunity to continue to work with the Children and Youth Behavioral Health Work Group, to continue to work with OSPI, to figure out how a comprehensive package that really addresses all of those needs that have either been identified, or we know we're identifying, OSPI is identifying, and our other partners are identifying, and our partners at the ESDs are identifying. I think we've got good mechanisms to sit down and have those conversations and move all of those recommendations forward. I will say it is a joint effort, and it will be Healthcare Authority along with all of the individual entities that do have a piece of children and youth behavioral health in the community and in the school system, which is a long way of me saying, I think Representative yes, we've got a lot of great information, a lot of great connections that we can leverage to work toward comprehensive packages, and building off of the work that the Children and Youth Behavioral Health Work Group and those recommendations that were put forward the last few years, we can build off of those as well.
And I just might add, Carrie, that I think we've got maybe two different streams of work that might build to a comprehensive package, but actually might be separate, depending on how we look at. One, we've got to figure out this community work, behavioral health workforce shortage. That has got to be a priority, and that is multi-pronged. That is not necessarily a K-12 problem. And, you know, I totally respect Martin's comments about K-12 does K-12, healthcare does healthcare, and we have to own that in that regard. So I think, Carrie, your point well taken in the sense of the combined effort on the K-12 side, we've got
My
to
answer
work
was very
together.
specific to that K-12. Yes.
But it's not going to work unless we have a workforce solution.
I agree with you.
And we are working on a plan for that. In fact, Carrie just shared this morning a very early draft concept of some work. Our State Healthcare Workforce Board updated its behavioral health strategy just last year. Again, I mentioned that potential certified clinical behavioral health model as one way to transform some of our behavioral health clinic and support payments. So we are working on components of that. I really would I do appreciate Michigan and South Carolina's all government approach to K-12 healthcare work. That was well financed, well resourced, and that's missing in the system today. So that might be a component for the legislature to consider as well.
Thank you. Let's go to Representative Berg, who, having served on 2 school boards, may offer us some great perspective here.
Yeah, well, thank you for that, Mr. Chair. And yeah, still currently serving on a school board, so it's still an active thing. That said, part of my question has to do with the school-based health centers and wanting to understand, I guess, a couple things. One is if the audit took those centers and the success potentially of those centers into account when making the recommendations, or were those seen as kind of such a small population that really wasn't a part of the audit findings? I guess that's for our state auditors.
Sorry.
No worries.
Back on there. Yes, great question. We actually did not, we talked to the alliance that oversees the School-Based Health Center Alliance during the audit, but school-based health centers were not actually included as part of the audit. And so it is not something that we looked in depth to within this audit. So, but one of the recommendations that we do make, Representative Berg, is about providing additional funding and flexibility with the funding. And part of that is because we do recognize the role that school-based health centers do play. But as somebody mentioned earlier, needs are different in different areas. So what may work for one area may not work for others. So that's why we made the recommendation the way that we did, to leave that open. So if it did work with the school-based health center, they could request that funding. If not, they could look at another alternative, just within the recommendations in general.
Perfect. And then follow up, if I may, Mr. Chair. So that said, and just so I understand it, so the recommendation leaves the ability to for districts to say, I guess what I'm getting at is if those have been looked at, it might not have been seen as so fragmented, right? Like in the gaps potentially wouldn't have been there if the schools or if the system was utilizing something like that. And so I guess, is there a way to clarify in the findings that that's a potential option? Because until Jason and Carrie kind of brought up school-based health centers, if somebody was reading the report, there would not be any thought that we actually have something in place that does integrate primary with behavioral that fills some of those gaps.
I see your point there. We didn't specifically mention it in the report, so you are correct about that. I don't know that would be something that we could actually change at this point, the report. But yeah, so it is something we definitely in our research with the audit noted that those were in place, but did not include that information because we didn't go into depth in looking at those as part of our scope.
Okay, perfect. Thank you for that.
Thank you. Senator Short.
Thank you. I think the computers are catching whatever they're catching because I'm having issues with mine. Thank you, Mr. Chair. And it's really more of a comment and an ask, I think. I love the discussion that we're having. And I think whether it was Martin's comments or Jason, yours about really looking at the options, the flexibility, the comfort level, you know, what a large urban school needs, a district needs, maybe a small rural school needs something that looks different, but still provides, you know, that access and those services. And so I would hope if you're looking at comprehensive things for what I'm thinking you're going to be asking us to consider, that you would really look at an array of options. You know, we're all, you know, agree, I think that this is critical, especially given the last couple of years of what our students have gone through and our families have gone through. But I think you'll really get so much more buy-in if it can be flexibly tailored, you know, to what the schools are. And if there's anything that you can share with our committee, especially with the audit, about maybe some of the work that the task force is thinking about in terms of options, man, that would be great if that's something that's appropriately shared at the moment.
Mr. Chair, just thank you, Senator Short and Representative Berg. I really appreciate and support that. Senator Short, I am happy to share a summary of all the programs, which includes a school-based health center. Our team did develop just a bit of a one-pager for that. I'm happy to share that. And I think as we go through the decision package process, we'll have more to share as the governor's budget is developed and so forth. So, but we, rest assured, we are working on that. And Representative Berg, we are in fact working with the school-based health centers on options along those lines as well in terms of supporting the school-based health centers, which again, I can't agree with you more on the importance of our school-based health centers and other models.
Thank you. So I want to go back to the Medicaid waiver coordination issue. In the arena of special ed funding, this has been brought up repeatedly, and we've heard from school district after school district that while the same type of Medicaid waiver is available for schools to get reimbursed and lower our state costs and their costs, because basically we're not coming close to fully paying for special ed in the state, for say behavioral therapy or speech therapy, Medicaid would be available in theory, but there are huge obstacles that have led districts to not pursue that. And so I see our HCA reps are nodding their heads, but I'm also curious about whether OSPI and our school districts have any thoughts about that.
Yeah, I don't know that I want to wade too much into the detail on that because I don't know the details. I know, similar to what you said, Representative Paul, we hear the same thing, that there are barriers to access. There kind of structural barriers. There's access to services, right? There's workforce barriers similar to what we talked about before, and then how can that be used in a way parallel to our K-12, special education funding to be sure the students who need it get the services that they need.
I'm not asking about doing it for K-12 special ed here in this context. What I'm asking is, are you aware if those same barriers, and maybe is HCA interested in exploring the idea that it would actually administer for, or OSPI would administer a waiver, and the administration that has been such an obstacle for districts.
Yeah, I'll just say thanks for the clarification. We in our response, we support the idea of thinking innovatively about our Medicaid program. I think Jason and Carrie talked a little bit about this school-based health work group that we have that's looking at what other states are doing. Other states are headed down that road. I think we need to be exploring what kind of flexibility we have. How can we work with the federal government, with CMS? What are the options that we have? What is on that edge of innovation that can bring services to kids in schools? We fully support that. We're very interested in engaging in that conversation.
I might just add, I think, Rep. Paulette, in addition, I think it's important to start with what we have, so that school-based health care service is different than the school-based health centers program for special ed, for IEP issues. That is a critical program. We have to support that program. And I think we can make some improvements within our existing structure if we fund that centrally, and don't make each individual school come up with its own Medicaid match to support that. So I think we could make some great progress, first and foremost, with what we have, including that effort, including our school-based health centers efforts. And I very much support working with CMS to see about other waiver options. We are not familiar with any other state with an innovative waiver option along the lines of what was referred to in the audit. And Martin and I have talked a little bit about this. We're going to talk to CMS about other concepts, and we do not want to foreclose those opportunities, but we need to be careful about what we take to our federal partners.
Are there any other questions or comments from committee members? I want to thank everyone for, it's just an incredibly important conversation to be having. And, the legislature has really begun to understand that we have a huge shortage. We've made investments in behavioral health teaching. Those things will take years to come to fruition, to be increasing the workforce. And frankly, our students and children can't wait. So we have to be looking at what we can do as effectively as possible right away. Any other closing thoughts, anyone? Thank you all very, very much for the work you're all doing. Appreciate it.
Thank you.
Thank you very much.
With that, let's be ready to move to the Medicaid program integrity at HCA. And if staff is ready to rock and roll, we can do that. All right.
We are ready. Representative Paulette, can you see my slides?
We can, yes.
Okay. Good afternoon, Representative Paulette and members of the committee. My name is Lori Ryman Garrettson with the Washington State Auditor's Office, and I am joined by my colleague, Marissa Sanchez-Reed. We are here to share the results of the audit, Medicaid program integrity, examining the healthcare authority's oversight of efforts at state agencies. Before we begin, we would like to thank the executives and managers at the healthcare authority for their time and assistance throughout the audit. When we started this audit, program integrity efforts were in a state of transition, and we found that managers were very open about the challenges they faced and their vision for program integrity in the future. Sorry. So first, I'd like to share a summary of our key audit findings. HCA executives recently created a division of program integrity to increase visibility of those efforts, but can improve oversight through improved strategic planning and performance measurement. Also, HCA has not provided federally required oversight of Medicaid program integrity efforts at sister state agencies. In addition, The division has expanded its program integrity efforts with managed care organizations, but more can be done to reduce the risk of fraud and other improper payments. And finally, improved audit selection practices would help the division prioritize resources for high-risk cases and meet federal requirements. Medicaid is a state and federal partnership that provides health coverage to people with low incomes. In Washington, Medicaid covers about 2 million people, which is more than 1 in 4 Washingtonians. In recent years, the cost of the Medicaid program has steadily increased, accounting for about $14.6 billion for fiscal year 2020. To participate in Medicaid, every state must designate one agency as the state Medicaid agency. This designation includes responsibility for several federal requirements. In Washington, the single state Medicaid agency is the Healthcare Authority. Program integrity is all about paying the right amount to the right provider for the right reason. Medicaid is a large program with a high volume of claims and complex rules, which increases the risk of fraud and other improper payments. Because of this, states must meet numerous federal program integrity requirements. Compliance with federal requirements is a necessary condition to receiving federal funding. This is a substantial sum. $9.5 billion of the $14.6 billion spent for Washington's Medicaid program during fiscal year 2020 came from the federal government. And the federal government can and has requested a refund of federal funding when program integrity requirements are not met. Also, strengthening program integrity efforts helps ensure every Medicaid dollar stretches as far as possible for those insured through the program. Our audit focused on 2 key questions. Are there opportunities for Healthcare Authority executive management to improve its oversight over program integrity? And how can the Division of Program Integrity improve its structure and processes to more effectively reduce the risk of fraud and other improper payments? And with that, I'm going to hand things over to Marissa, who will share more about what we found.
My name is Marisa Sanchez-Reed, and I'm a performance auditor at the Office of the Washington State Auditor. Because HCA is the state's Medicaid agency, Healthcare Authority executives are responsible for oversight of program integrity efforts. The purpose of executive oversight is to ensure public agencies achieve expected results. In 2020, HCA executives consolidated many of the agency's program integrity efforts into the Division of Program Integrity. Although HCA executives have taken steps to consolidate program integrity efforts, this work would benefit from improved strategic planning at the agency and division level. HCA's agency-wide strategic plan makes only limited mention of program integrity, and it does not set clear objectives that focus on program integrity efforts. The division also lacks an approved strategic plan. While HCA executives conduct some oversight of program integrity efforts, they can improve their monitoring through better use of performance measures. Recurring one-on-ones are important, but not intended to provide an operational overview. In addition, several committees support the state Medicaid director, but none oversee all program integrity efforts. Furthermore, HCA has some program integrity performance measures, but lacks others recommended by experts and used by other states. Barriers include the agency's lack of an IT solution that uses data analytics to detect fraud and other improper payments, frequent organizational restructures, and the lack of an approved strategic plan with program integrity objectives. HCA leadership has a system to regularly review performance measures, but it does not include the limited measures the division has. As part of the federal Medicaid grant award, HCA is responsible for overseeing all Medicaid program integrity activities, including those at other state agencies that pay providers with Medicaid funding. In both the state Medicaid plan and the cooperative agreement between HCA and DSHS, HCA recognizes it has an oversight role to ensure Medicaid funds are spent and services are provided according to federal and state laws and regulations. HCA internal policy also recognizes this responsibility. and HCA assigned responsibility for ensuring other state agencies comply with federal program integrity requirements to the division. Of the $14.6 billion spent on Medicaid in fiscal year 2020, DSHS spent $4.7 billion, while DCYF spent $56 million. DSHS primarily uses this funding to provide long-term care for the elderly and people with disabilities, and DCYF primarily uses this funding to provide supports and services for children and young adults who have complex needs and experience significant behavioral health challenges. DSHS and DCYF report having processes in place to ensure Medicaid funding is spent appropriately. However, HCA division managers said they have not been providing formal oversight for DSHS's program integrity efforts, nor have they ensured that DSHS submits program integrity reports required by the cooperative agreement and HCA internal policy. The DCYF financial manager has no contact with or direction from HCA, nor has the division required DCYF to report on its program integrity efforts. This is due to three key causes. The division has not assigned oversight of sister state agencies to any of its units. Instead of a single plan, HCA has multiple documents that outline roles and responsibilities created at different times and without reference to each other. And lack of a clear plan contributed to confusion and gaps in knowledge when HCA experienced organizational changes. For example, one division manager did not know the 8-year-old cooperative agreement with DSHS existed, and therefore did not know about the program integrity requirements it contained. And now I'm going to turn it back over to Lori so she can talk about MCO accountability.
Thank you, Marissa. Similar to how HCA is expected to oversee program integrity efforts at sister state agencies, HCA is also expected to oversee program integrity efforts at managed care organizations. Washington has steadily transitioned most of its Medicaid clients away from fee-for-service, where the state Medicaid agency pays providers directly for each service rendered, to managed care, where private insurance companies provide specific services in exchange for monthly payments. Currently, in Washington, about 85% of Medicaid clients are in managed care. Managed care requires a different approach to program integrity, and the MCOs play an important role. Numerous federal program integrity requirements must be included in the contracts with the MCOs, and the division is responsible for ensuring the MCOs meet these program integrity requirements. Monitoring MCO program integrity efforts is a relatively new responsibility for the division, and the division is establishing ways to hold MCOs accountable for their role. For example, the division requires the MCOs to regularly report on their program integrity efforts, and division managers meet quarterly with all 5 MCOs and the Medicaid Fraud Control Division. Also, the division recently finished its first audit of MCO encounter data, which describes each visit every patient makes to all of the MCO's providers. The division's audit found violations ranging from minor administrative errors to changes in the amount paid, which could affect future premium rates. HCA executives sanctioned the 5 MCOs a total of nearly $1 million for the issues identified in the division's audit. In addition, HCA recently updated its contracts with the MCOs to allow additional financial penalties if the MCOs do not meet their program integrity requirements. For example, if the division finds that an MCO overpaid a provider, it can collect up to 5 times the amount overpaid in liquidated damages, because that overpayment would be reflected in the rates paid to all 5 MCOs. The division could further improve its oversight by directly auditing providers contracted with the MCOs and recovering overpayments. In 2019, the division started a preliminary review of providers contracted with the MCOs, but never started formal audits due to uncertainty on how to recover any potential overpayments. After all, HCA did not pay the providers, the MCOs did. This question has been resolved through the contract updates I just mentioned, and division managers are finalizing these processes. Part of our audit looked for opportunities to improve oversight. Another part looked for opportunities to improve the division's processes for selecting audits, reviews, and investigations. In addition to overseeing program integrity efforts at sister state agencies and MCOs, the division also regularly reviews, audits, and investigates providers to identify fraud and other improper payments. When the division identifies potential fraud, it conducts a preliminary investigation and sends any credible allegations to the Medicaid Fraud Control Division. Our audit identified ways to improve those processes. Risk assessments help auditors make the best use of limited resources. The division has not used risk assessments or formally established risk factors to guide its audit plans. Instead, its work plans have consisted primarily of federally required audits and following up on leads that the division has received. Also, while division staff review data for suspicious activity, such as repeated billing for a procedure that should only occur once per client, only 2 of the 4 units rely on data analytics to build out their work plans. In addition, federal regulations require the state Medicaid agency to determine the credibility of fraud allegations. However, MCOs and DSHS have been sending their fraud allegations directly to the Medicaid Fraud Control Division. While the MCOs and DSHS provide HCA a copy of these referrals, contrary to the federal regulations, the division has not reviewed them to determine if any of the allegations are credible. This means the division cannot identify the many provider issues that would be best addressed through administrative remedies instead of criminal indictment. Furthermore, Washington's MCOs regularly report leads to the division. Analyzing these leads would help division staff gain experience and monitor MCO engagement and program integrity. The previously mentioned lack of a fraud and abuse detection system has resulted in numerous large Excel spreadsheets, which has made it challenging for division staff to do this analysis. And finally, the division would like to establish a collaboration with a unified program integrity contractor, which is a federally recognized expert in reviewing claims across Medicare and Medicaid to look for providers inappropriately billing both programs for the same care. The division has not been able to establish the collaboration due to differences in understanding about how the relationship should be structured. However, division managers report these issues have been resolved. The Healthcare Authority agrees with our recommendations and has already started implementing many of them. The full text of our recommendations is available in our report. In summary, we recommend HCA executives provide consistent oversight of program integrity, either through the existing committee structure or by establishing a committee focused on overseeing program integrity, work with division managers to improve strategic planning for program integrity, and ensure the most critical measures related to the division's success are included in the agency's overall performance measurement processes. We also recommend division managers improve strategic planning, oversight at sister state agencies, program integrity efforts with MCOs, and audit selection practices. As we conclude this presentation, we'd like to let you know the State Auditor's Office is preparing a concise report summarizing our Medicaid audit program. And that concludes our presentation, and we would love to address any questions you might have.
Thank you very much for presenting, Lori and Marissa. Just wondering, would Assistant Director Brown like to share HCA's view?
Sure, and thank you, Chair Paulette. Good afternoon, and thank you for the opportunity to be here today. We would like to thank the SAO for their collaborative effort during this audit. I felt like it was truly a collaborative effort. I was relatively new to this position when the audit began, and I truly saw this as an opportunity to help reinforce a lot of the changes that the agency was already going to make or were making. And I felt it was important for us to really be collaborative during this process. And I felt that ultimately it was a good result. In their report, they identified 19 recommendations for the Division of Program Integrity. The implementation of these recommendations, or many of these recommendations, has already begun. And even in listening to Lori's report and Marissa as well, some of the things are already outdated, and I hope to be able to update you on those a little bit later. Protecting Medicaid resources is extremely important to the Healthcare Authority, and implementing these recommendations is going to help to enhance that effort. In addition to this audit, I wanted to be able to provide a little bit of context, because in 2019, CMS also performed a focused review and released recommendations as well, and the Legislature supported HCA with additional resources to help implement those recommendations. We will be submitting a report later this year on those recommendations this fall on the implementation. And I would like to report, we just recently were able to get staffed up. We had hiring freezes through the pandemic, but we're very excited to implement these changes because as the SAO has pointed out, there are some gaps in where we were previously at, and we're working to correct those now and look forward to implementing them. Thank you.
Thank you. So let's open it up for questions for the Auditor's Office or HCA. Representative Gaynor.
Thank you, Mr. Chair. This is kind of I'm not sure exactly who's best to answer this, but with the Auditor's Office, I mean, my experience, often there are suggestions that are given, you should come up with a plan, but there's really not a lot of concrete guidance in how that plan should be formulated. So can you help me maybe understand a little bit about how the accountability of developing the plan that would be responding to the suggestions that of changes that should be made? Is there a template that of some sort? I mean, within the organizational structure that I'm not aware of, and can you share?
Representative Gaynor, I'm happy to address on our end and I believe it was recommendation number 7, where the Auditor's Office recommended the statewide fraud and abuse prevention plan, which is an excellent recommendation, and we're already and within that recommendation, they've identified several bullets to include. We've already assigned that recommendation out, and we have a plan to implement that plan.
So could I clarify, Mr. Chair?
Please do.
So then, Mike, when you have this plan, you have a plan that you feel addresses those bullet points. I guess my question is, what if, is there someone that's analyzing whether that fully addresses the bullets that have been laid out for you?
So a lot of the requirements that will be contained in that plan are federal regulations or state regulations that will be included in that plan. And so certainly we work with the Attorney General's office to make sure that we're complying with all the laws and rules as we're developing these plans. And HCA leadership is going to have to sign off and approve on the plan as well. So there is oversight over the plan, and we do use the Attorney General's office heavily because this is such a heavily regulated area.
Okay, thank you.
Going to ask both of you a question, having had the delight of reading MCO contracts with HCA and supervising students reviewing them. What is the right balance between holding HCA to the MCOs and the MCOs being accountable for the integrity and oversight of the providers that they're paying?
I can certainly take a shot at this. And from my perspective, we contract with the MCOs, and part of that contract requires them to perform program integrity activities. And if they're failing to do that, then we have the ability within the contract to sanction them or impose liquidated damages. And in part of the report earlier, I believe Lori mentioned, we don't audit MCO providers and recover overpayments. And we've opted to take the other path, which is work through the contract, identify those overpayments, and then penalize the MCOs for them. And then the MCOs are under contract. They should be required to go and do the program integrity work and recover that overpayment. We're going to report what we find with the actuaries so it won't impact rate setting. And then the MCOs will have to do what we're paying them to do, which is to go recover the overpayment. And that's the option HCA has opted instead of the other approach is also called a finders keepers approach, where in other states, the Medicaid agencies will go and identify overpayments MCOs made and pull them back from the providers.
Representative Fine.
Thank you, Mr. Chair. How does the work of this audit interrelate with what must be pretty stringent federal audit requirements? I take it the feds must come in and with the amount of money involved and make sure that the money is correctly spent. So how does this integrate with that?
I'll defer to Lori on how they reviewed for the audit.
Yeah.
And then I can answer as well.
I'll answer, and then Mike, let me know if there's anything you would add. So the Washington State Auditor's Office does the federally required single audit for the state of Washington. And so our scope for this audit was developed in consultation with SAO's single audit team. So we learned from the single audit team what repeat program integrity findings have looked like and listened to their counsel and had a single auditor as part of our initial audit team. And then as part of the performance audit, our audit team did some of the federal single audit work. Does that answer your question, Representative?
Well, I guess have a follow-up, Mr. Chair.
Please.
So have problems been identified that for some time now that came up again in this particular work? It sounds like this might be a problem that's been around for a while.
So there are some repeat audit findings that relate to program integrity requirements. Sometimes audit findings are repeat findings because it takes time to resolve the issue. And so in that case, and sometimes it's because of the timing of the single audit that it results in a repeat finding. Does that address your question, Representative?
Yeah, and all right, so I presume given the nature of this is an annual audit.
The single audit is an annual audit. Yes, sir.
Okay, thank you.
And do we have any, yes, Scott from the State Auditor's Office, please.
Thank you, Mr. Chair. I just wanted to, hopefully this will help clarify with the single audit versus the performance audit. The single audit, which is conducted by our office, is an annual audit of federal funding. It covers the entire state, covers all sorts of federal programs, but because of the size of Medicaid, Medicaid is included every year, and it's really focused on compliance with a set of requirements for different aspects of the program. It delves a little bit into like when there are findings, what the causes are, but they're not going to go very far into that. A performance audit like this is less about compliance and more about what are ways we can improve this system, which is really beyond what the single audits can do. So what we were looking at, and really in concert with HCA, was to say, what are some mechanisms, some things that could be done that would, up the game with regard to program integrity. And so we worked with our single audit teams, which is a different team within our agency, to make sure we understood what they were seeing, what their understanding of the program was, so we didn't duplicate their work, but instead built on it. But our focus was less on compliance with rules and more on how to bring the program forward with hopefully, and what I think HCA would concur, some useful recommendations around this. So I'll just clarify, I could get a little bit confusing around this, but what the difference between this annual audit of requirements and compliance versus sort of a one-off project like this that's looking for program improvements.
Thank you. Any other clarifications? Anyone else like to offer any comments or views? So it sounds as if HCA is well on its way to implementing many of these recommendations. And although it's a little bit unusual, there's no formal role in doing so, but I would ask that you share with us an update on that progress at some point when it's appropriate.
Yes, we would absolutely love to share progress notes on this. I'm excited for the changes that are coming to the Healthcare Authority, and so I'm going to be happy to share them with everybody.
Okay. Thank you. With that, I think that we've gotten to the good of the order, and I want to remind people that public testimony can be emailed in to us at JLARC@leg.wa.gov. The next I-900 subcommittee hearing is scheduled for September 22nd at 1:30 p.m. And I really want to thank the staff of JLARC for putting together the panelists today and all the presentations on the JLARC agenda, and then for the State Auditor's Office and all the panelists and guests today for really informative and answering our questions, and really very good discussion. And thank you to all of the JLARC members. Any other good of the order? All right. In that case, we will adjourn. Thank you all very, very much.